this week on the BackTable podcast.
I would say appropriate counseling is very important. I would give an advice about, you got to tell any patients to do a procedure on, especially HoLEP, about the retrograde ejaculation, no matter how old he is. I got an 86 years old very angry at me because of that before, and I learned the lesson. So it's very important to counsel everybody on retrograde ejaculation when you are doing a HoLEP, and decide if they cannot imagine having retrograde ejaculation, then HoLEP or a TURB is not for them. We might need to seek another option. If also they cannot imagine the transient urinary incontinence, then also HoLEP is not for them. We gotta look into different options.
Hello everyone, and welcome back to BackTable Urology podcast, your source for all things urology. This is Jose Silva as your host this week. And today we have Dr. Marawan El Tayeb. Dr. El Tayeb received his medical degree from Alexandria University, Egypt in 2005 with honors. He completed his urology residency at Alexandria Main University Hospital in 2010. He then finished a pediatric urology fellowship at Cincinnati Children's Hospital in 2013. And after that, he went on to do an endourology fellowship at Methodist Hospital, Indiana University in 2015. Dr. El Tayeb joined Baylor Scott and White-Temple in 2015. He is currently the chief of the urology division, vice chair of the Department of Surgery at Baylor Scott and White-Temple, and a clinical associate professor at Baylor College of Medicine. Marawan, welcome to the BackTable.
Oh, thank you, Jose. Thank you very much for the opportunity. Excited to be here.
So we're going to talk about BPH. Prior to talking about BPH, just talk to us about, you've been 10 years out of practice. Tell us how your practice is. What are you doing? What do you do the most?
Well, I practice in Temple, Texas, which is a town about 45 minutes north of Austin. I'm at Baylor Scott and White in the main hospital, which is the flagship hospital of Baylor Scott and White system. My main practice is mainly BPH, either medical and surgical management, and stones, medical treatment and surgical management, ureteroscopies, PCNLs, and about 60% of my practice is BPH and about 40% stones.
And regarding, so we'll be talking about BPH in the past 10 years. What they used to offer 10 years ago, and what are you doing now?
Sure, yeah, great question. So when I first started out of fellowship, I came out from Indiana University, pretty heavy program in terms of enucleations of the prostate, mainly holmium laser enucleation of the prostate. And probably a year in, this is the main procedure I was offering. And I then started diversifying the procedures I'm offering, especially with the introduction of mist treatments. So I started offering lift procedures for patients who are interested and motivated to seek that option. I started offering Resume at some point, which is the thermal treatment. And I offer every once in a while transurethral resection of the prostate. I like doing still a good TURB. But about 80% of my practice is enucleations of the prostate in terms of BPH management.
And you get referred by other urologists in the area to do that procedure?
Yeah, we have patients coming all over. We have patients coming from 35 states in our program. We have built a pretty robust program. When we first started, I was lucky enough to be the first one in Texas, and then we trained many residents, and now about 1,000 HoLEP procedures are done in the state of Texas between me and my trainees, which is great, honestly, to offer that to patients.
So let's talk about the patient. So let's say that patient goes to your clinic. Let's talk about a naive patient, first time, hasn't seen any other urologist, goes to you. What are you doing to that patient on that initial visit?
Sure, yeah. Well, first thing, I start always getting some vital signs. I want to make sure he's not hypertension and all that, and not tachycardic, not an AFib and all that. And then just take some history first. And have you had any other procedures done before? How long has this been going on? And I like questionnaires. I like as a AOA symptom score, IPSS, quality of life symptoms. I get that. And then we like using a phrase in the questionnaire, how motivated he is on seeking minimal invasive or surgical management, just to get an idea about where is this patient in his search, in his journey, what other treatments he had in the past, either has been alpha blockers, has been 5-alpha reductase inhibitors. I always get a urine in the first visit. I always get a post-void residual. The guidelines still, they don't recommend that in the first visit, but I always get that. I like getting that. I always try to look in the chart in terms of, does he have any imaging, any CT scan within the last 5 years, any ultrasound, anything like that, just to get an idea. Most patients now had some sort of imaging, and that can save a patient a step in terms of management. And then go from there. It depends on how the visit will take me after that.
And what would you say? Most of your patients that go to see you, I mean, they're already thinking about a procedure?
I would say about 90% of the patients come and see me. They are already kind of ready and made their mind that they want some sort of a procedure. About 20%, I would start them on medical therapy. I like still giving patients alpha blockers to start with and see them back and see what is progress. I always try to differentiate between obstructive and irritative symptoms, and I treat nocturia completely separate because that's a separate set of patients that we try to deal with completely different. I want to make sure that any comorbidities are managed first, sleep apnea, if they have nocturnal polyuria, or if they have edema. All that, I kind of try to tackle all this stuff before jumping into surgical intervention.
And let's say that patient that you see in the office, I mean, you mentioned nocturia, and it's always, all the patients that come to the office, well, I wake up 3 times, or I don't wake up at night, I'm good. So they always, I mean, the media has created that propaganda that nocturia is probably the most predictable symptom of BPH. I mean, but the history is not that. Just for the audience, I mean, how do you have that talk about nocturia and sleep apnea, and because it's a difficult talk, and most patients don't understand it. I mean, it's like you're talking something different. It's not that what they know.
Yeah. So I always use a phrase that, you know, if the patient is married or in a relationship and has a female partner, I ask, like, you know, does the wife wake up at night? Yes. And most of the time, yes, because most of the bad habits that are done in the house, same, like people will drink, like, you know, or have supper late at night, and they drink at night, either, you know, alcohol or non-alcohol, and drink a lot of fluid. So most of the time, their spouses will wake up at night as well. And so, like, you know, your spouse probably don't have a prostate, so it's not related to prostate all the time. And we try to differentiate that. And I try to take a good history regarding sleep apnea and heart disease, and make sure that they understand it doesn't mean that they wake up at night is the prostate is a problem. And we tackle that. And I like getting avoiding diary, especially if I'm seeing this patient like a first time and it's a naive patient, as you said. And avoiding diary will tell me a lot regarding, you know, either their habits or how much they urinate at night. And that can guide where we are going.
And you mentioned the irritative symptoms. Sometimes some patients, only irritative symptoms, good flow, no obstruction, already irritated, but you do I mean, let's say the patient had a CT scan and has a very big intravesical lobe. How do you tell the patient, hey, you might still need a procedure even though you have a good flow, and it's a difficult conversation sometimes with the patient. How do you talk about that with those patients?
Yeah, so if the patient is having an intravesical protrusion of the prostate and has the irritative symptoms, probably, and most of the time, these symptoms are coming from the median lobe, as you said. And I tell them, if you want to treat that, we can try to treat that with either anticholinergics or P3 agonist. However, we are treating only your symptoms. We are not treating the cause. It's a completely different conversation when this patient does not have any intravesical protrusion of the prostate or does not have a median lobe. And I try to make them understand that. We have some diagrams in the office that we can show them, like median lobe coming in, and I show them how this can impact their symptoms.
And with all the evidence now that we need to be defending the truth or bladder health, trying to prevent any damage, has your approach to patients differed in the past 10 years?
Not really. We've been consistent with the guidelines most of the time and making sure that, you know, we are consistent. The only thing I've become more careful with as more evidence come about the anticholinergics and linking that to dementia and linking that. So I become less prescriber of anticholinergics, especially in older folks. And if I would prescribe it, I would prescribe something like a trospium does not cross the blood-brain barrier or less to cross the blood-brain barrier, especially in older folks. And I become more dependent on beta-3 agonists for older patients, especially now with Gemtesa is now on the market, which can help with the problem with the blood pressures that we used to see with the mirapagram.
So let's say that patient is motivated to do a procedure. How do you go deciding what's the best option for that patient?
Sure. So I kind of put a few parameters. First of all, what is the age of the patient, sexually active or not? What is his status of ejaculation? how important is ejaculation to him, and does he have retrograde ejaculation now on alpha blockers? Most of the patients now are on alpha blockers, and most of them already have retrograde ejaculation. And it would be very surprising to find out that the patient does not even know that the tamsulosin would cause retrograde ejaculation. So I try to get all this information in because that's a big decision making. And then I would have some sort of an assessment for the size of the prostate. And this is consistent with the AUA guidelines. If the patient has already an imaging, like either a CT scan or a transrectal ultrasound, and as you said, is naive, he doesn't have a procedure before and less risk of urethral strictures, and this patient does not necessarily need a cystoscopy. But if he doesn't have any of that, if he doesn't have a recent imaging or doesn't have any of that, then I would do a cystoscopy and make sure and assess the size of the prostate with a cystoscopy or transrectal ultrasound to get an accurate size. And then I would divide the prostates into 3 categories: less than 30 grams, and between 30 to 80, and above 80 grams. And then I would counsel based on what they want.
What do you usually offer for those small glands, less than 30 grams?
I would offer either transurethral incision, or I would offer a HoLEP, because HoLEP is the only procedure that is size independent based on the most recent data. And we'll go from there. Usually for that small size prostate, I would like to get a pressure flow study and urodynamics. I want to make sure that this is really the problem, because most of these patients are the younger kind of group of patients. And I want to make sure that I have like a good bladder pressure before doing anything. I want to make sure that you are not having like a super overactive bladder that need to be controlled before doing any procedure. Because a lot of times you make that incision, and if the patient has a severe overactive bladder that was undiagnosed, then it will get aggravated and patients will not going to be satisfied.
And when you're deciding a miss versus a HoLEP, for example, I mean, what difference do you tell the patient? What's that conversation like?
Yeah, sure. So I would tell them that the HoLEP has the most robust data, has the most long-term data beside TURP. It has been studied now for close to 30 years since its evolution in 1998. And I would tell them that the recurrence rate is very low, and they're probably going to do very well and less likely to have any other procedure for the rest of their lives. I would tell them that the missed, if we elect to decide to go with that option, it's fairly short-term. It's associated with higher recurrence rate. However, if their prostate is less than 80 grams, they are probably going to reserve their ejaculation. They are probably have less side effects on the short term than a HoLEP. And I usually let them decide what they want to do. Most of the patients, I would say, they elect, especially if they are in the older group, I would say 70 and up, they would elect to proceed with enucleation. However, most of the younger patients will decide to proceed with missed unless they have extra large prostate.
And are you doing the miss in the OR or in your office?
I do it actually in the office. I always tell the patient, if we're going to put you to sleep, let's try to do a surgery. So I do it in the office, and we have a pretty good setup for it in the office. I mainly do a resume and a urolift in the office. We do a prostate block, and we have the option of a nitrous gas that we give them in the office, 50-50 nitrous gas, self-administered. It's a kind of a patent device. And they do very well. I always tell them it takes about 2 to 3 minutes, but it feels a lot longer. And if we talk to people like this way, I think most of them would agree on proceeding.
Question regarding the prostate block. I mean, have you tried doing just the Pronox, or have you seen the comparison between just Pronox versus both?
I've not tried to do without a block. I found that the block gives them a little bit kind of better state of mind in terms of, we're doing like nerve block for your prostate. I don't know, like we have not done, I think, any studies regarding to studies that.
No, you're just asking, yeah.
Yeah. Well, that's actually a good question and might be a good study to do.
No, I heard. I mean, some people are doing just like a tramadol, gabapentin, and an Ativan, and they're doing the resume. So everybody has their own little book. It would be good to know what is the best, most efficient, patient satisfaction. It would be good to know.
Yeah.
So Marawan, so let's dive into HoLEP. You've been doing HoLEP for more than 10 years now. When you counsel the patients about HoLEP, how's that conversation like in terms of side effects, what to expect those first couple of days?
I tell them that it's kind of 50-50 chance either they stay in the hospital or go home same day. It depends mainly on the size of their prostate. I tell them there is a risk of bleeding. It's about in our series, it's about 3% risk of bleeding and required like prolonged CBI, a small risk of infection, and definitely the elephant in the room, the incontinence risk. And that incontinence risk has significantly decreased with the early mucosal release and sphincter sparing technique. And that's definitely increased significantly after that. When we trained to do HoLEP, we used to do it like with encircling, and you put a little tension on the sphincter. And definitely the short-term incontinence was high. Short-term incontinence rate was high. It was reached about 60 to 70%. And then it goes away. And I don't think that on the long term, both procedures are different. Both techniques are different. However, in the short term, definitely the early mucosal release is better. Now the incontinence, short-term incontinence around 20%. And then it goes down to less than 1% at 3 months. So there is a significant benefit for patients on the short term. I tell them definitely about the risk of the retrograde ejaculation. That's very important. And I tell them about the rare risks of injury to the bladder with a morcellator or injury to the urethra. I always tell them that the erections will be the same. I'm not taking anything. I'm not adding anything. Some patients, however, in some series has reported that they had a marginal improvement in their erections, but there is no studies really to kind of definitely point that. And I would tell them that they will have blood in the urine for about 2 weeks, and they expect it will get better and better, and they will have a significant improvement in their obstructive symptoms. I like kind of separating obstructive and irritative symptoms into 2 sections. Obstructive symptoms, this will immediately get better. The irritative symptoms may take up to 6 months to get better. And it is very important to set the expectation because a lot of patients do not differentiate between the urge incontinence and the stress incontinence. And I try to counsel them on that. And that's get better, and we'll get better with time.
In terms of equipment, what do you need to start doing HoLEPs at the hospital?
So when we first started, as there was only one company that offers most of the equipment in terms of the enucleation portion, and another one company that was offering equipment for morcellation. So Storz was only offering, like at that time, the laser resectoscope, and basically Luminous, that is now Boston Scientific, was offering the morcellator. As a morcellator at that time, for people who remember, about 10 to 12 years, was that going back and forth morcellator, and it was very dull. It was reusable, and it was not very efficient, and it's actually was kind of painful. And then it came the Wolf morcellator around 2014, and that was a game changer. It's a rotating morcellator. It is disposable, and it is very efficient and much better. It requires a learning curve in terms of troubleshooting the machine, but it was a significant advancement. In terms of the enucleation portion, we moved from the laser resectoscope that was offered by Storz. Now we have the Shark equipment offered by Wolf, and we have actually the mini HoLEP equipment that is not yet available in the United States. It's about 22 French laser resectoscope, but it's not yet offered in the United States. It's not FDA approved, or the company is not offering it to my knowledge till now. When we first started, it was a 28 French, and we moved down to 26 French, and now there is a 24 French, and 22 French is available in Europe and South America. So there's definitely advancement. So it depends on what you're comfortable with. But what I would advise people, you want to get a 26 or 24 French laser resectoscope of some sort or form, and then you want to have a good laser. I would recommend a laser that is 80 watts and above. However, there are some series and there are some trials that have tried HoLEPs with 30 watt laser and with good success. Either pulse modulation or no pulse modulation, that depends really on where you are and what is your budget really, because that can increase, like can have $100,000 more in your budget. And then I would recommend the Wolf morcellator with a Barana. It's pretty efficient, pretty good, and consistent, works all the time. But if you don't have that capital investment for as a Wolf morcellator, you can have the Cyberblade, which is a disposable quantum morcellator, which is new in the market and actually works. It requires a little bit of a learning curve, but it works.
And when we're talking about doing the HoLEP part, removing it from the prostatic fossa, how long in average does that part takes you?
Well, when everybody first started, it takes a long time. Usually like kind of explaining it in grams per minute. So there are actually pretty good study back in 2010 that was describing like people first learning how to do HoLEP would take them 2 grams per minute to enucleate. And the morcellator, it depends on the quality of tissue really. But on average, 2 grams per minute when you're starting. But as you advance, you can get to 1 gram per minute or even less than that. Usually, most enucleations, if it is less than 100 gram prostate, it should take less than 30 minutes, the enucleation portion. And then the morcellation portion would take, it depends on what is the size of the prostate. The Wolf morcellator, unfortunately, because of the quality of tissue and the visualization and all that, so the data is all over the place. If it is all feasible, all good circumstances, it can go up to 20 grams per minute. But sometimes it does 2 grams per minute. So it depends.
Wow, okay. And question, I mean, the morcellator, do you go through the same sheath that you use for the laser?
We have an offset nephroscope for the morcellator.
Okay.
And it's a stores scope that we want to use, but Wolf has now, they made like the full setup for enucleation, morcellation kind of, and now they have a pretty good setup for everything. But it's different. So if somebody's trained on the stores equipment, it will be a little bit of a learning curve to get used to the Wolf.
And for big intravesical lobes, I mean, what's the technique? How do you make sure that you're not going in too deep into the bladder? How that part works?
So first step is you try to find the ureteric orifices to make sure that you are away. A lot of times if the patient has like a big intravesical lobe, usually the ureteric orifice is very close to the median lobe, and median lobe is already covering it, and it's difficult. So a lot of times I found it very useful in the beginning, if you can find the ureteric orifice, is that to close the outflow of your continuous flow resectoscope. That will distend the bladder and push the ureteric orifices a little bit away from the median lobe, and you can see, you can kind of find out where they are, and you can make that incision at that time at the bladder neck and take it down to the vero. However, sometimes it's not feasible, and it becomes kind of nerve-wracking. So I try not to start at the bladder neck. I try about maybe a half centimeter distal to the bladder neck, and I take the incision to the vero. And that usually kind of buy me some time till I'm able to see the ureteric orifice once I mobilize that median lobe. But a lot of times, unfortunately, you don't know what it is till you enucleate.
That must be scary. That part of me, I guess, if you're doing a lot, you get used to it. But definitely for that first, somebody start doing it HoLEP. I mean, I guess start with the easy prostate first.
Yep. So that's actually a great point. I always recommend if somebody starts learning, you want to try a good size. A good size for starting your doing HoLEPs is between 60 to 80 grams. I found less than 60 is a little bit difficult. Above the 80 for beginners can be challenging. So the golden kind of size is 60 to 80, because you can always bail out. You can always do a TURB with 60 to 80. So if you can't proceed, you can just buy Bowler's TURB and just TURB it.
And just out of curiosity, with smaller glands, you meant those less than 30, do you see a little bit more incontinence, or really doesn't change anything?
So in the beginning of when I was doing it, when I was doing HoLEP for smaller glands, I was enucleating, like really enucleating and going down and such. And I found later on when we started analyzing the data and writing up and understanding incontinence and HoLEP, we found that this is really not necessary. So we try to not to get around the sphincter 100% like bigger glands, because most of these patients' problem less than 30 grams is actually at the bladder neck and at the more proximal half of the prostate. So I try to spare completely the mucosa around the sphincter and maybe go about half centimeter proximal to the sphincter and enucleated that area completely away from the sphincter. So the incontinence risk is actually for those patients right now, it's in my experience is similar. It might be better because we are extra careful with these patients, but we try to enucleate the bulkier lateral lobes and the bladder neck, definitely, because this is a problem.
Okay, so you do the procedure. When do you decide if this is going to be a patient that stays overnight or you can discharge? Is it right there? Is just what happens impact you with the bleeding?
Sure, yeah. So some patients we decide in the beginning that they're probably going to be better to stay. Patients who are on chronic anticoagulation or antiplatelet, we try to stop them prior to surgery, but if they are on it, that means that they have significant health conditions that requires probably observation, and they will serve this way. Patients that are morbidly obese, patients that has diabetes, patients with like high readmission score. Now, if any electronic medical record will give you a good scoring on these patients and it's calculated its own, or patients with high fall risk. Those patients, though, I would not even try to send them home same day, because these patients can come back and will come back probably. But we're talking about an index patient, as 60 years old, 60-gram prostate, fairly healthy, fit. This is a patient I would counsel them at the beginning. You're probably going to go home, but we will see what's the color of the urine going to be in PECU. And then we do the surgery. If there is no bleeding at the end, it looks clear, we put them in CBI, 1 or 2 bags, just because when they are waking up, they usually give it a cuff or 2 and they can bleed a little bit. So we run 1 or 2 bags of CBI and watch them. Usually we have a protocol. The nurse knows very well our protocol, and they would stop it after 2 bags and watch it. If he's doing okay, meeting criteria, they would go home. Usually I do a voiding trial same day. So about 99%, the catheter comes out less than 24 hours. And they do very well. Our first time voiding trial right now is close to 90%, which is, they do very well.
You mentioned CBI, but also are you putting them in traction?
Not really.
Not really? Okay.
Yeah, not really. Before the pulse modulation, we used to put many patients on traction, but now, no. I usually like to put like a small sponge on the catheter, but not on traction, just to kind of keep the blood in so it doesn't leak around the catheter and doesn't generate that unnecessary foam call. But at the same time, keeps tamponating the urethra and the area of the prostate.
And in terms of the balloon, do you inflate at 20 or just 10 mL is fine?
Well, it depends on the size. If they are any prostate less than 30 grams, I usually put like 30 ml in the balloon. It depends really on how big the bladder neck is, because most of these bladder necks will be huge at the end. So I usually put 60 in the balloon for bigger prostates. Rarely anything above that, probably like 10%, 80 ml, but never anything above that.
Okay. And what do you use? A 22, a 24, 20?
I use 22 French,
22.
3-way.
And in those patients that are more tendency of bleeding, do you go higher or you just do 22 for everybody?
I would say about 95% would be 22 French, 3-way. Yearly, when you get that humongous prostate, the bleeding is not stopping, you did everything, and still the bleeding is not stopping, I would put it like a 24 French hematuria catheter and all that. But this patient, I won't let him leave the OR unless I did everything in terms of like hemostasis with the laser. But if the bleeding doesn't stop with the laser, because a lot of, for this humongous prostate, I'm talking about like 300 or 400 gram prostate, and the bleeding is just unbelievable. After you finished and did everything, especially have been on blood center, then we can do a bipolar kind of, fulguration at the end for any kind of significant bleeding.
And in those cases, I mean, you remove a 400-gram prostate. Do you see the capsule shrinking at that immediately, or?
Yeah, they collapse.
Okay.
So it's kind of surprising. Collapse pretty good. However, I call it like if this patient get an MRI, and now with the utilization of MRI for elevated PSA, so some of these patients would come back and 3 or 4 years with an elevated PSA for a reason or another, and they get an MRI, and surprisingly, you see what I call the Tesla sign. Okay, the bladder would be riding up, and then the prostatic fossa will look like the bottom of the Tesla. And it's pretty fascinating, but the fossa collapse pretty nice, even with this prostate. It may take up to 6 months, but they usually collapse.
And question, so after the procedure, what medications do you give the patient?
So during the procedure, we give them a single dose antibiotics. I like either 2nd or 3rd generation cephalosporin. If the patient has a catheter in, and even with a negative culture, I try to give them cefepime, because that would cover Pseudomonas. So this is kind of unique for patients who has catheters. So because the 2nd and 3rd generation would not work, Rocephin would not work on Pseudomonas. And after surgery, I just keep them on CBI. I try to stop the fluid as soon as possible. And then the IV fluid, I'm talking about the IV fluid. I try to stop the IV fluid as soon as possible, regular diet as soon as possible. I try to kind of simulate the environment of home. And then I send them home, usually it depends, but I usually send them home on 3 days of antibiotic. Either culture specific to whatever cultures they had positive in the past, or if they didn't have any positive cultures in the past, I still give them like nitrofurantoin or Keflex just for 3 days. It's not guideline recommended, I know that, but it's kind of the way I was trained. We tried to stop it, but we had some infections. We're actually right now doing a prospective randomized trial, and we're looking into that. I would submit this project to the AOA this next year, so we'll sure that we will have kind of some feedback about that.
So you do the antibiotic for 3 days. Anything else? Pyridium, stool softeners, for example.
Yeah, we tell them to take Boridium or Azo, PRN, over the counter. I give them Miralax or Bisacodil. It depends on if they are constipated or not. But, it depends on their symptoms. If somebody's regular, has no problem, we try not to give any narcotics, even in the hospital at all. And they are rarely in pain. But if they have really pain, and I would give them some tramadol, but nothing like narcotics. We try not to.
So let's talk about some special considerations. So let's say you have a patient with a proven Gleason 3+3 on active surveillance. He has obstructive symptoms. Is that patient a candidate for HoLEP?
Yes, that's actually a very, very important category, and thanks for bringing that up. Because it becomes problematic if this patient is on active surveillance and says that he has a 100-gram prostate and his PSA is above 10 now, and it really is not meeting that active surveillance protocol and makes everybody nervous and everybody want to do something. If this patient, we have a protocol with our radiation oncologist. So if they have any patient that we refer to them to radiation for whatever, Gleason 6, Gleason 7, and not meeting the criteria of active surveillance anymore, he would send me for evaluation for size, for if he would benefit from any intervention, or this patient is meeting the criteria. But for the specific patient that is just meeting in that category of active surveillance, his PSA is less than 6, he has a big prostate, and he has obstructive symptoms, we do the enucleation. And we look at the PSA, some period between 8 to 12 weeks. We found that the golden time to check the PSA after everything settles. Usually in these patients, if they don't have clinically significant prostate cancer, their PSA should go down to less than 1. If the PSA does not go to less than 1 after enucleation, it will require further attention. We don't have to do anything at that time, but it will require further attention. It depends on what is the level of the PSA. Say it's 1.5, we will get a PSA in 3 months and make sure trending that PSA. If it is trending up, then something else going on, so we will get an MRI and then go from there. Some of these patients will require a biopsy. And also it depends on what kind of the pathology would come out of the HoLEP specimen. Say it came back with, and most of these patients come back with BPH, and some of them will come back with still the same Gleason 6. And we can continue active surveillance with this patient. But if they upgrade or upstage, that's a different conversation, and we would have it very early on.
So you mentioned early on, what would be the next step for those patients? So I guess in treatment, a radical prostatectomy is still an option, or those patients will probably go to have XRT or some sort of radiation?
Yeah, it depends on the age. Usually in our institution, if less than 70, healthy, not much significant comorbidities, they would go for a radical prostatectomy.
So you will treat just as usual?
As usual, taking into consideration that the bladder neck might need some construction at the time of the roll and require some closure. But if they are not meeting the criteria of radical prostatectomy, then we have a very close partnership with our radiation oncologist. We are very lucky to have him. He kind of understands, really. He writes an excellent urology notes. I tell him that. So we have this partnership, and he would do either hyperfractionated radiation or fractionated radiation, and we have this protocol with him, and they do very well. But there is an important set of patients that are referred for radiation. They have a Gleason 7 unfavorable, intermediate risk, or high risk, Gleason 8, 9, and 10, and they have a large prostate, and they are referred for radiation. These patients are not usually candidates for radical prostatectomy above 75, multiple comorbidities. He sends these patients to me in advance, and most of these patients, we do a HoLEP on them, and they end up getting radiation usually 3 months later. And they do very, very well, because it becomes problematic if this patient has a lot of obstructive symptoms and you do radiation. Usually they have a lot more symptoms after the radiation. And then what we do next, because if we end up doing an enucleation or a TURB, especially if it's a good TURB, they will end up having significant incontinence. But there is also this kind of 60-gram prostate with significant intravesical protrusion of the median lobe with a Gleason 7 or 8 prostate cancer, and they have radiation. It makes the radiation oncologist very nervous radiating that intravesical portion, because they will end up having radiation cystitis a few years later with a lot of problems. So understanding this helps a lot.
And Marawan, question, that patient that you're going to do a procedure that is going to go for radiation, and those patients that are getting ADT treatment, do you wait until you finish the ADT to see if the prostate has shrunk? Or, for example, if the patient has a medium lobe, you just go ahead and do it?
Yeah, we just go ahead and do it. I rarely find that the ADT, especially for that huge prostates, will shrink the prostate significantly to either reduce the symptoms or reduce the median lobe. At least this is from our experience. Maybe some other people have some better experience with it, or there are some data, but I really found it. So we give them, if it's a high-risk prostate cancer, and they will get an ADT, and then we'll proceed with the HoLEP and send them back. And the trick is that they have to wait about 3 months after the HoLEP, at least 3 months. And want to make sure that their symptoms are mostly gone. And if their symptoms are not gone, then I would like to assist to them, make sure that there is a good healing in the prostatic urethra. Because if they are still like not completely epithelialized in the prostatic urethra and you radiate them, you're going to end up by having like a lot of dystrophic calcifications that will be like a huge problem later on and very, very difficult to fix.
You just make sure that there's no irritative symptoms, no burning, no dysuria, incontinence also. Just make sure that the patient is already continent.
We try to make sure that they're already continent. Unfortunately, some of these patients, a very small group of them, about 10%, after being completely continent, after the HoLEP, they end up having radiation, and then they start being incontinent. And then it becomes like a little bit problematic, and it's mainly, unfortunately, due to the radiation effect on the sphincter and prostatic urethra and the mechanism of voiding itself. And these patients are managed later by one of our reconstructive urologists if it becomes bothersome enough.
And Marawan, in terms of, where does pelvic floor therapy, Kegels, do they have a role in getting continence back after this procedure?
Yeah, great question. So we counsel patients early on the risk of short-term incontinence. We tell them do not start any Kegel exercises on your own before 2 weeks. After 2 weeks, then usually the bleeding is settled, everything is fairly normal. They can lift, they can work out, they can do that. Then if they have stress incontinence, then they already have the instructions of the Kegel exercises. We are lucky enough in is that we are in an era, there are a lot of apps on like the phones, for example, Kegel Nation. They would kind of show them some Kegel exercises and train them. So they can do that early on. As a follow-up visit, at some point between 10 to 12 weeks, if they are still having incontinence, and usually I'm talking about like the 10 to 12 weeks is about 10% of patients, we kind of assess how much incontinence they're having, how many beds are they using. And then we send them to Kegel for formal physical pelvic floor therapy assessment and biofeedback and Kegel exercises. And they do a great job in that 10% of patients. And then that takes the percentage down to about 1 to 3% at 6 months. If the patient still has incontinence at 6 months, that's probably not going to improve. Probably. And then we will have to counsel them on how much it is bothering them and do they need another procedure to fix that.
And Marwan, anything else we miss during the discussion? I think we cover a lot of topics.
I would say appropriate counseling is very important. I would give an advice about, you got to tell any patients to do a procedure on, especially HoLEP, about the retrograde ejaculation, no matter how old he is. I got an 86 years old very angry at me because of that before, and I learned the lesson. So it's very important to counsel everybody on retrograde ejaculation when you are doing a HoLEP, and decide if they cannot imagine having retrograde ejaculation, then HoLEP or a TURB is not for them. We might need to seek another option. If also they cannot imagine the transient urinary incontinence, then also HoLEP is not for them. We gotta look into different options.
What is an option for a patient, 120 gram prostate, that doesn't want anything that will cause retroejaculation?
Well, you can try now based on the Water 2 trial. You can try aquablation.
It's 10%. So it's not zero.
Correct, but it is better than the HoLEP, so you can try aquablation. And also, it depends really on the planning on aquablation, right? And if the patient already has like a big intravesical protrusion of a median lobe, then it becomes problematic and you're still going to have a retrograde ejaculation. It is a problem in the 120 gram, to be honest with you, category. Less than 80 gram, yeah, we have, use a Urolift if they don't have a median lobe. if they have a rhizome, if they don't have a median lobe. There are some trials and some techniques that you can do with a HoLEP, which is the hood above to the viro, like you leave a little bit of tissue in the apex and flaps, but it becomes a problematic when you are doing this huge prostates. So above 80 or 100 gram, I would tell them it depends. If you want to keep your ejaculation, you gotta have to kind of pick between urinating or ejaculating normally.
Prostate artery embolization, does that come into the equation? I mean, when for that specific patient that doesn't want any sexual side effects, is that, or at least any problems with ejaculation, is that in the conversation?
I bring it up at some patients that are completely unfit for surgical intervention, to be honest with you. I found that, and I know the data from interventional radiology are okay, but this has not been my experience. We have done a fair number of patients post-prostate artery embolization, and most of them would need something else to be done. Or at least this is a patient I see, they probably have a problem. I'm sure that I haven't seen there's 1,000 other patients that they did not have a problem. You can bring it up, you can counsel them on, it's done by interventional radiology. You gotta find the right interventional radiology for that, because it has to be somebody high volume, and not really the interventional radiologist that in your hospital that done once a year. So it will require some resources, and it will require a high volume interventional radiologist. That's how I would counsel.
So Marwan, anything else you want to add?
Well, I think you guys are doing a great thing, and thanks for having me. And you have been a great host.
No, so Marwan, thank you for being part of BackTable, and hope to meet you in person soon.
Sure. Yeah, we'll see you the next AOA.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.